Well, again, this tiny piece of spring arriving, even if it's now in early May, has brought with it some relief from all that rain. However, there are always things ongoing as the seasons change. I love the Isle of Man in May. It's not too hot, it's relatively dry. The flowers are finally popping their heads above the parapets, and that sky so blue without all that heat haze. However, we find May is often migraine starter month, and this year we may find a spike in hay fever cases too, given all those suppressed pollinators raring to go. Only in recent years have the causes of migraine started to become uncovered through neuroscientists working in the United States, Sweden and the UK, for example. A few notable locations involved. As opposed to the very common day-to-day tension headaches we all have from time to time, not psychological tension, but rather muscle tension arising from several muscle groups located in the head and indeed neck. Typically prescribed as a band around the head, feeling so tight it's crushingly tense, hence the term tension headache. Migraine, although it may mimic this in some souls, usually is quite different. We now know this via vital research from, for example, Professor Moscovich, a Harvard professor of neurology, who way back in 1979 proposed a theory that the complex interaction of certain nerves in the head, namely the trigeminal nerve, the tri giving us the three main branches, each side of which supply much of the scalp, face, down to the chin on each side. These nerves interacting with numerous fibres which supply the very sensitive brain-covering meninges, of which again there are three layers, the outer dura mater being the most likely interaction. Here so-called neurotransmitters, initially thought to be stuff called 5-HT, 5-hydroxytryptamine. Once liberated, initially causing certain brain-covering arteries to constrict, to tighten, followed by a burst of dilatation, a stretch. The area served by these arteries then causing the well-known brain effects of classical migraine. 1 in 10 have an aura, a warning of what's to come. From visual changes, kaleidoscope vision, a blind spot, wiggly lines, or even temporary partial blindness in the area of the visual fields, to nausea, cravings for certain smells or food, light avoidance, yawning, vertigo. Anything goes then. Then comes the severe headache, sometimes later, but occasionally never, which in some cases can actually mimic a mild stroke in older folks. The headache usually, though, one-sided, associated with nausea or vomiting. Often again it tends to be just the sufferer-centred. It's very unique to each person, each case. This may, it could last minutes to days, occasionally weeks, yes, weeks, affecting about 1 in 7 of us worldwide. It's about 3 times more common in ladies, losing the UK millions of working days annually, so it's a very significant disorder. So back to the research then, wherein not 5-HT, 5-hydroxytryptamine, but following some excellent collaborative work from scientists in Sweden and the UK, it was discovered that the causative chemical was actually a weirdly named widget termed CGRP, calcitonin gene-related peptide. I knew it was on the tip of your tongue. Whoa. In the early 2000s, large clinical trials began showing the results of this using CGRP blotting agents, and they worked. They were extremely effective in blocking the effects of this in migraine. A host of medications have since arrived, promising, if not to abolish migraine entirely, at least make severe sufferers much more likely to live a better life in terms of severity of attacks and attack reduction. Of course, back in 1991, triptans were launched, a very specific treatment for migraine along these same lines. Dramatically effective they remain, and they really are effective, with about a 70% or so effectivity rate, and several are now available, given by all means, from oral, and if you're vomiting, a nasal spray, or an injection, or even a patch. However, several contraindications to their use remain, because you can cause significant and slightly non-specific artery constriction in both brain and coronary circulations with triptans. So if you can imagine, If it's taken once the aura or warning symptoms have started to fade, pre-bursting headache, in other words, it's great. But they can also produce brain and circulation issues. So lots of contraindications like untreated high blood pressure, cerebral or cardiac arterial disease, coronary artery disease, or angina, pregnancy, under 18s, bar 2 versions of this, over 65s, etc., etc., significant liver or kidney disease. So many contraindications. So it's not a magic silver bullet. So with some joy last month, the UK Migraine Trust welcomed the accession to targeted treatments for migraine in the UK with a new, one of many new agents that have been around in the United States for years, but this was a slightly weird name again. Atogepant. This is designed to initially be prescribed by hospital specialists for those migraine sufferers who have failed at least 3 specific chronic migraine treatments, of which there are several, of course, used for severe chronic cases, for instance, more than 15 attacks monthly, or having, say, between 4 to 15 acute attacks a month. It's not cheap, by any means, as nothing is these days. About £8,000 a year per patient. So, well, let's just see. But that's just a flavour of the world of migraine. Maybe let's do headaches and treatment, or yes or no next. That might be interesting as well. But for now, cheerio.